Good morning and warm welcome to Online Anaesthesia Postgraduate Teaching Program on Zoom platform, sponsored by Acrola and hosted by A1 Logics and aired by Anaesthesia TV. Today is a great day. We have two international legendary pediatric anesthetists to deliver lectures for our postgraduates. I take this opportunity to share with you how this phenomenal moment happened. I am a staunch follower of Airway GD blog. I was taken aback by Dr. Christine's way of explaining the depths of subject. So the first thing that struck my mind was, it could be a great if our postgraduates gets benefited by her lecture. The hindrance I faced was all her lectures were paid and we run our program free of cost. But when I approached her, she generously accepted my invite. Thank you, madam. And her two books, that is Anyone Can Intubate and Pediatric Airway Management, a step-by-step guide are must read for every postgraduate out there. After fixing her appointment, the next hurdle in the path was to find an equally experienced international faculty, but that ended as a cup of cake because the only name that came to my mind was Dr. Ramesh sir. His impeccable teaching record requires no special introduction. That's how this dream eventually became reality. My excitement knew no bound. Before starting the session, we have few instructions to the viewers. Since it's an international event, we expect spam in the chat box. So chat box is inactivated. Please note the chat box is inactivated. You can post your questions directly to me. My name is Dr. Edward Johnson, or to the coordinator, Dr. Gomathy, or to the host. The questions will be addressed by both speakers at the end of the session. So without much further ado, I request Dr. Gomathy madam to coordinate the session. Dr. Gomathy madam is working as an associate professor of emergency medicine in the prestigious Madras Medical College. Over to you, madam.
Thank you, sir, and a happy day to all of you. This is an international event which we've been waiting for a very, very long time. I am honored to introduce Madam Christine E. Whitten. And as sir said, she's an author of Whitten Step-by-Step Guides, and she has written a series of books on airway management, which will lead you step-by-step to whatever you need to know about intubation and respiratory care in both pediatrics and adults. Her newest book of the series is Pediatric Airway Management, which has caught our attention very vividly, and that is why Madam Whitten is here. So Dr. Whitten believes that education leads to better patient care, isn't it? All of us believe that too. Her books, as well as her training videos on intubation and airway management, are used in training programs both nationally and internationally. A description of Madam Whitten's career. I hope I do justice to it. Dr. Whitten received her medical degree from Johns Hopkins Medical School in 1979 after her anesthesiology residency at the U.S. Naval Hospital in Portsmouth, Virginia. She completed fellowships in regional anesthesia and intensive care. Following training, she was on the teaching staff, and she served as a director of regional anesthesia in the U.S. Naval Hospital in San Diego. So when she left the Navy, she left with the rank of commander. Following that, Dr. Whitten joined the staff at Kaiser Permanente San Diego in 1987. And from 1987, she continues to work as chief of anesthesia and director of perioperative services. She is also the regional coordinator of pain management, and she was involved in implementation of multidisciplinary chronic pain management programs for Kaiser Permanente throughout the country. Now, I think that is phenomenal. She has completed the entire spectrum of anesthesia, beginning from intubation, looking after, and now she's gone to chronic pain management also. We are incredibly honored to have her here. Madam Christine, it's over to you. We are waiting to hear you talk. Thank you.
Well, thank you so much for that, Madam, for that very kind introduction, and good morning. As you heard, I'm Dr. Christine Whitten, and greetings from the other side of the planet, from here in San Diego, where it's currently night. And I would like to really thank you for the opportunity to talk to you today about a very important subject: how to make anesthesia safer for our littlest patients. So let me bring up the slides here. Okay. And why? There we go. Okay, sorry about that. I am going to be talking to you today about common pediatric airway problems and their solutions, but I could just as easily have called this lecture Pediatric Anesthesia Can Be Scary. I love this picture because it reminds me of how my non-pediatric anesthesia colleagues usually react when they come in first thing in the morning and see that there is a small child on their operative list. Basically, anesthesia for children can be very intimidating. They obstruct easily, they get hypoxic quickly, and if they get hypoxic, it often causes bradycardia. And if you look at the statistics, anesthesiologists who do less than 100 cases of infants and children less than 2 years old a year, they have 5 times greater risk of complications than those who do more than 200 cases a year. And if you look at those complications, 1 in 5 are severe complications, and we're talking about things like laryngospasm, esophageal mainstem intubations, all the way up to cardiac arrest. And basically, it's important for us to take into account that anesthetizing children is different. But my goal is not to scare you out of taking care of children. My goal is to basically, I don't want fear to stop you. Most children have easy airways and healthy hearts. And basically, if you go ahead and prepare what you need ahead of time, take the differences in anatomy and physiology into account, and are methodical and gentle in how you treat the patient, you're not going to hurt the child. It is simply essential that your pediatric patient stays oxygenated and ventilated. So let's look at what we need to do to decrease that risk for our patients. As anesthesia providers, we are experts in airway management. And when we're doing a case, it is sometimes unfortunately easy to forget that there is a child attached to that airway. And that child has an increased risk of hypoxia and respiratory failure for a variety of reasons. First of all, they're very tiny compared to even my small hands. They have a nervous system that's immature. Their physiology is such that children get hypoxic quickly. Their upper airway predisposes to obstruction. Intubation can certainly be more challenging from all the way from the small size to the difference in the anatomy. Laryngospasm is unfortunately very easy to get into. And then, of course, there's medication and the fact that these children are setups for overdoses and drug errors. So let's take each of these in turn, and let's start out with the most obvious thing is size. Now, this is a child I actually took care of in Hue, Vietnam. We had just finished a 2-week mission, and we had packed up all of our equipment, and quite literally, we were getting ready to leave the hospital to leave the next day when a mother brought in this newborn who had a hemifacial cleft. And this child only weighed about 2 kilograms. And obviously, in my opinion, it wasn't safe to do any sort of major operation on this child, much too young, much too small. And not only that, I didn't have any airway equipment that was small enough to really manage this child's airway. But my surgeon wanted to throw in a few stitches to close the eyelids to protect the eye as best he could. And he said he could do it under local anesthesia, and that sounded fine to me. And he said, would it be okay if I just dropped a couple of drops of lidocaine in the baby's eye? And I said, that sounded safe to me. And so he immediately dumped 3 cc's of 4% lidocaine into this baby's eye. So that's 120 milligrams of lidocaine into this 2 kilogram child. And the baby instantly became unresponsive. Now, the surgeon was thrilled because he now had an immobile target, and it was very easy for him to put in his stitches. I myself was terrified because I realized that we had just overdosed this baby and I didn't have airway equipment. But fortunately, fate was kind because the baby kept breathing. And this is actually me here holding this baby's head in a perfect position to keep him breathing. And in about 30, 35 minutes, he woke up and started to nurse and everything was fine. But in this case, the baby's size, the lack of equipment, infant physiology, medication error, and an incredible amount of miscommunication on the part of the providers led to a totally avoidable near miss. And I bring this story up so that as you're taking care of children in the future, you realize that there are no details too small to think about ahead of time. You really have to prepare. So always have equipment of the right size. And if you're dealing with things like endotracheal tubes, have the next size larger and the next size smaller. You don't have to take them out of the package. You don't have to break sterilization, but you do have to have them immediately available so that if you need it, you don't have to have somebody go and look for it. Now, children have an immature nervous system, and basically that can get them into trouble in a whole variety of ways. But one of the most critical ways is that their parasympathetic nervous system is much better developed than their sympathetic nervous system. They basically eat, sleep, and do other things that are not sympathetically related as they're growing up. So if you remember nothing else from this lecture, remember that if you see bradycardia in a child, assume that it's hypoxia until proven otherwise and treat it that way. And the reason is this: if you or I or an older child gets hypoxic, we're going to have a sympathetic response. And that's going to raise our blood pressure and our pulses. And if we get bradycardic, it's a late and very dangerous sign of imminent cardiovascular collapse. If a baby gets hypoxic, and then they often will get bradycardic as a first sign. And once bradycardia starts, you get into this vicious cycle because children, and we'll get into this a little bit more in a moment, tend to be rate dependent for their blood pressures and cardiac output. So bradycardia quickly causes decreased cardiac output, and that worsens hypoxia, and the baby gets acidotic, and then you get more of a depressed myocardium, which causes hypoperfusion, and you go around and around very quickly, and cardiac arrest can happen in minutes. And so again, if you see this, you have to very urgently treat with ventilation, oxygen, and usually that's enough to cause the bradycardia to resolve, but you always have to bear in mind that you might need epinephrine or atropine to treat this. You do not want to get into cardiac arrest. Now, other ways the nervous system gets a child into trouble is their immature brain. They've got incomplete nerve myelinization, their blood-brain barrier is poorly developed at birth, and they have a relative lack of exposure to drugs. Like my 2-kilogram child in Hue, Vietnam, this is what got us into trouble to begin with. Now, the opposite side of the spectrum is also true. It's easy to over-medicate a crying, combative child. And especially if you're really trying to control one that's out of control, it's very easy to give too much. So titrate opiates and sedatives slowly, use small doses, monitor the effect carefully, and remember, you can always put more in. It can't take it back out. Neonates have underdeveloped respiratory centers, so you need to monitor them longer. If they have less than 60 post-conceptual weeks, if they have a history of apneic spells, it's better to perhaps even keep them overnight, and that's what we do here in the United States. Avoid narcotics if possible. And then I don't think there's any adult on the planet that doesn't know that children can be uncooperative. Well, why does this make them a setup for respiratory failure? Well, first of all, if they're struggling, it's hard to pre-oxygenate them. They have increased oxygen consumption and they have increased work of breathing. And then if they're crying, they have increased secretions, airway edema, airway irritability, a tendency, if they have a tendency towards bronchospasm, to wheeze. and you've increased the risk of laryngospasm. Now, this is in an uncomplicated child. If you have a child that already has respiratory distress, croup, epiglottitis, or an airway foreign body, you can actually tip them over into respiratory failure if you allow this to happen. Now, sometimes it's unavoidable, but if you can, avoid stressing the child. Don't scare the child if you can. If you don't have to put all the monitors on when you initially are treating a child that's in distress, just use the ones that you need. Use the parent. Some parents are, as long as you tell them what's going on, you explain what it is that you need them to do, they are often very comfortable taking care of a child and calming them. We'll very frequently, if we think that it's safe, use mask induction before starting an IV, but this is kind of predicated on them not being an aspiration risk, on them having a cardiovascular status that's not going to collapse if we anesthetize them. So it has to be safe, but mask induction before IV often works. And then again, there's the question of pre-medication. Just remember that if you have a child that's in distress and already exhausted, a little bit of pre-medication can go a very long way and can potentially get you into trouble. Immature physiology is also something that we have to keep in mind because children get hypoxic very quickly. Their baseline metabolic rate tends to be 2 to 3 times the adult. Now, if we get a stimulus, well, if any patient gets a stimulus like increased carbon dioxide or a lower oxygen or increased acidosis or stress, the response is an increased respiratory rate, increased tidal volume, increased heart rate, and increased stroke volume, because what we want to do is balance out oxygen supply and oxygen demand. And respiratory distress and failure occur if oxygen supply can't meet oxygen demand. So how well are prepared as a young child to deal with this? And I think I said this at the beginning, but I'm going to be concentrating really on the differences with babies and children less than 2 years of age, because those are the children that most tend to get into trouble. So alveolar ventilation in a child that young tends to be rate dependent. Their surface area of alveoli is about 10 to 20% of the adult. Well, that actually translates to the alveolar surface area of a baby being about the size of a baby blanket versus the size of half a tennis court in an adult. It's huge. Tidal volume is smaller. Functional residual capacity is about 75% smaller than the adult. And the anatomic dead space is higher. It's about 3 milliliters per kilogram versus 2 milliliters per kilogram. So basically the pediatric oxygen tank is smaller. And that means they can't hold their breaths as long as an adult. And their cardiovascular system is also immature. They tend to be rate and volume dependent. And because of that, bradycardia and hypovolemia tend to cause hypotension and poor perfusion fairly quickly, as opposed to what will happen with an older child and an adult. And that's true because their ventricles tend to be stiffer. There's decreased contractility and decreased stroke volume. There's smaller muscle mass, so they don't have as much peripheral muscle to mobilize plasma to the central circulation if they get hypovolemic. There's decreased sympathetic tone that we've already mentioned. Well, that means their stroke volume increases are limited. They have increased parasympathetic tone. Hypoxia tends to cause bradycardia. Their liver has limited drug metabolism. Not only is it slower, it varies with different drugs. And in the United States, we are now trying to avoid the use of codeine in children. As we all know, about 10% of codeine is metabolized to morphine, but there's a variant cytochrome P450 that some children and adults have that hypermetabolizes codeine to morphine. And in those patients, especially if you're an infant or a young child, it can be enough to over-sedate and potentially cause apnea. So the recommendation here in the States is to avoid codeine in patients who are less than 12 years old, who are less than 12 to 18 if they have sleep apnea, and in breastfeeding mothers. So it's just something to bear in mind, that that's a drug that used to be considered fairly safe in children that we now have to use with caution. Hyper and hypothermia, we don't think of that as causing problems with hypoxia, but if you're hyperthermic, your increased metabolic rate will increase oxygen consumption and change that demand supply equation. And if you're hypothermic, shivering increases your oxygen consumption. Now, if you're a newborn, you can't shiver. And so you're relying on brown fat metabolism, which increases oxygen consumption 3 to 4 times. So not only can you get use more oxygen, you tend to get a little bit more acidotic. And so again, keeping normothermia, which we wouldn't normally think is something is helping us with respiratory distress or failure, is something we need to keep in the back of our mind. So you can say this with any patient: avoid hypoventilation, avoid bradycardia, hypovolemia, and anemia. But in an infant or a child, these things can get you into trouble very quickly. And then that brings us to anatomy. Anatomy is actually most different in infants and children. Children are not small adults. And we know this because when we look at a child, we can often tell how old the child is simply by looking at their head size, the shape of the head, the facial characteristics, the length of the neck, and the body shape. So it shouldn't be a surprise to us that the inside of the child is changing as well. Infants who have the greatest anatomical differences have the highest risk of airway obstruction. And the larynx is a really good example of that. The infant larynx starts short and omega shaped. It's softer and more easily deformed, compressed, and even obstructed. I once watched an obstetric resident deliver a baby who was squirming and struggling, and he had his hand wrapped around the baby's neck to keep the child from sliding away. And the baby looked like he was crying, but you couldn't hear anything. And then his attending came over and he said, "Lift your left thumb." And he lifted the thumb up and the baby let out this loud wail. And just by pressing on the baby's neck with his thumb, he was causing enough airway compression to cause obstruction. The infant larynx is located higher in the neck than an adult. It's opposite cervical vertebrae 2-3, as opposed to about 5-6. And all of these things will change how we manage airway. I'm sure a lot of you have seen pictures like this before. I'll run through it really quickly. Infants have narrow nostrils. They're obligate nose breathers when they're newborn. Their occiput is much larger and rounded compared to the rest of the head, which makes it a little bit floppy, a little bit hard to control when it's laying there. The tongue's relatively large for the mouth. We talked about the epiglottis shape before. The larynx is higher in the neck. The vocal cords slant anteriorly, and that means the endotracheal tube will sometimes hang up a little bit more easily on the anterior commissure. The neck's short, and then the cricoid ring is the smallest diameter. And I'll go into why these differences are a little bit more important to us in intubation and airway management in a moment. But have you ever thought about why babies are so different? And babies are so different because they're built to suckle. And those things tend to set them up for airway obstruction. The infant feeding is a very complex process. It requires precise coordination of sucking and swallowing and breathing all at the same time. And those things are mutually exclusive. So when the infant nurses, the already high larynx actually further elevates, and it effectively locks the epiglottis and the uvula together into the oropharynx. And the soft palate fits snugly around the larynx and forms a constricted passage. And then liquid passes through these two passageways on either side of the epiglottis, so that the baby can actually swallow while they're breathing. The tongue's relatively larger relative to the mandible. It fills the mouth. It angles slightly forward to cover the gum line. All of these things allow it to suckle. But it also means that the baby is an obligate nose breather. From newborn until about 5 months of age, the infant, unless he's crying, breathes primarily through the nose and can suffocate if the nose is obstructed. And in fact, choanal atresia, which is a congenital obstruction of both sides of the nose, if it's on both sides, it can cause obstructed breathing at birth, which can actually be an emergency. So while all of this allows the baby to suckle easily, you can see how this is a real setup for airway obstruction. In addition, the larynx is funnel shaped. And that means that the narrowing predisposes to obstruction. Also means that we need to choose a smaller endotracheal tube size relative to the size of the trachea than we obviously would with an adult. Move forward. And that narrowness can also predispose to problems if there's circumferential edema. So this is an infant airway, and here's an adult airway. And so average adult airway, let's say it's 8 millimeters. If we get 1 millimeter of circumferential edema, that takes us down to 6. That's a 44% decrease in cross-sectional area and an increase of 3 times for resistance. But what about the baby? So let's start with a 4 millimeter airway. We have 1 millimeter circumferential edema, and now we only have a 2 millimeter airway. So that's a 75% decrease in cross-sectional area and a 16 times increase in resistance. And basically, you can see that edema from swelling, from infections, or even from intubation trauma will be having a much more devastating effect in an infant than in an adult. Older children around 5 to 6 years old tend to have very large adenoids and kissing tonsils. And you can see with the kissing tonsils here on the right, that there's not a whole lot of air for passageway for air. And this U-shaped structure right here, that's the epiglottis. And that shows you how high in this particular child that epiglottis is. Now, pediatric mechanics of breathing also increases the risk of respiratory failure. The chest wall is much more compliant. There's a lot less ossification, so there's decreased elastic recoil, and exhalation is going to require some work. They're abdominal breathers. If you look at the shape of the chest wall, it's more box-like. They can't really expand their chest cavity like an adult can. And so when they take a deeper breath, they're more reliant on the diaphragm going down, pushing the abdominal contents out. And so you will actually see if babies are taking a deeper breath, their abdominal area will pooch out. Chest wall, like I said, is much more box-like. That's mechanically inefficient. It limits lung expansion, it limits tidal volume, and it makes them more respiratory rate dependent. And then there's the muscles of ventilation. They only have about 10 to 20% of type 1 or slow twitch fibers, and those tend to tire a lot more easily. And finally, because of all of those things, when there's partial obstruction, you tend to get this rocking chest wall motion where the chest actually will go down while the abdomen goes up. And that limits lung expansion. It increases the work of breathing, and it makes it the harder an infant tries to breathe, the less efficient it becomes. And so again, if you have a child that has obstruction, or if a child is sick, the mechanics of breathing can cause them to tire much more quickly. So it's important for us to be able to recognize the signs of airway obstruction. This is a little boy with croup. You can see there's not a whole lot of head bobbing here, but that's more likely to be seen in infants, but there's a tracheal tug. There's rib retractions. There's that paradoxical breathing where the chest is going in and the abdomen's coming out. The neck muscles up here are tensing. He's in the sniffing position because that's the position of the head and neck that's going to cause the airway to most be open. And this is a silent video, but I'm sure there was stridor here. And of course, snoring is also a sign of airway obstruction. Now, point out to the fact, getting back to let's not scare the child, that this child is obviously being observed, but there aren't a whole lot of monitors on this child. Mom is holding the baby in her lap, and you can see that there's EMLA cream here on all of the obvious IV sites, so that when they do start this IV in this child, they won't frighten the child quite so much. Opening the airway has to take anatomy into account. Extreme flexion and extension of an infant's airway can obstruct the airway. And there are actually case reports of infants being suffocated, sometimes fatally, by placing them in extreme flexion position to do a spinal tap. And so you really have to be mindful when you have a child in an awkward position to make sure that there's air exchange. The infant has a much more rounded occiput. And it tends to be more effective to place a small roll or towel underneath the baby's shoulders, so that you're basically trying to bring the ear and the sternum in a little bit more of a straight line. With a toddler, their occiput is already starting to become more flat. And you're either not going to need a roll at all, or if you need one, it's going to go now a little bit more underneath the back of the head. But again, look at the child and see what the child needs before you automatically put a roll underneath the child's head. Getting back to size of equipment, you really need to have the right size oral airway. Too large an oral airway will tend to obstruct the epiglottis itself, and too small an oral airway tends to put the end of the airway right in the middle of the tongue, which can not only bunch it up and cause obstruction, but it can also, if it's in for any length of time, obstruct the lingual vein and cause swelling and edema. And a large airway will sometimes protrude outside of the mouth far enough that you can't get the mask on the child. Now, one way of measuring whether you have the right size is to put it along the outside of the child's face and see whether it reaches from just outside the teeth or the gum line back towards the angle of the jaw. Same with nasal airway. Now, we don't often use a lot of nasal airways in children, especially toddlers, because they tend to have large adenoids. And not only can you get into nosebleeds, you can also kind of amputate some of the adenoids as you're going around the bend, which can then lead to a foreign body in the airway. But if you are using a nasal airway, you want to use the correct size. If it's too long, it will actually irritate the epiglottis and cause coughing. And of course, if it's too short, it won't actually pass into the posterior pharynx. And so one way of, again, testing size is to see whether it reaches from the nares back towards either the angle of the jaw or the earlobe. Now, ventilation has to also take into account the anatomy and as well as the chest wall dynamics. You want to avoid flexion and hyperextension of the child's head and neck. You need to obtain a good mask fit, and that means having the right size mask. You want to rest your fingers on the mandible, not on the soft tissue underneath the chin, because like I said, if you press underneath here, sometimes the airway is so soft that you can obstruct it yourself. The eyes are in risk because the face is smaller, and so the eyes are much closer to the edge of the mask. You want to watch the chest expand when you're ventilating a child, and you want to avoid insufflating the stomach, because as soon as you insufflate the stomach, the diaphragm is going to rise and it's going to limit your tidal volume. Sometimes to the extent that you might actually have to pass a soft suction catheter to empty the stomach. So ventilation, you want to pre-oxygenate, you want to ensure good ventilation, and you want to minimize any apneic periods. Alveolar ventilation and tidal volume are something you really have to pay attention to in a small child. You want to use the appropriate tidal volume. Now, in this comparison, what we have is a healthy teenage boy who's 60 kilograms and a healthy infant who's 2.7 kilograms. So in our teenager, 60 kilograms, if you use 8 milliliters per kilogram for a tidal volume, that's about 480. Anatomic dead space is 2 per kilo, that's about 120. 480 minus 120 is 360. So his alveolar ventilation baseline is about the volume of a can of soda. In our infant, 2.7 kilograms, 8 per kilo, tidal volume's 22. Anatomic dead space is higher at 3 per kilo, so that's 8. 22 minus 8 is 14. That's about the volume of a tablespoon. There's a huge difference there, and you can see that there might be a high risk of barotrauma. So when you're ventilating, you want to make sure that you watch the chest rise. You want to make sure that the airway is open so that that tiny little tidal volume here is going into the lungs and not the stomach. You don't want to inflate the stomach. Now, we don't often think about our equipment having dead space, but it does. And if you look at a pediatric mask, it's much lower in profile than an adult mask. And the reason for that is to try to minimize the amount of wasted ventilation. So when I'm squeezing the bag to ventilate my child, the gas volume that I'm giving not only goes into the child, it goes into the anatomic dead space of the trachea and the upper airway, and it goes into the mask and the elbow. And if I don't take the volume of the mask and the elbow into account, maybe I'm not ventilating the lungs. And that, again, you need to watch the chest expand. This picture over here is an adult, but it's an LMA with one of the rather unusual filters that we were using there for a while. It's a fairly high volume filter, and our circuit at that time had a fairly large amount of dead space, and I measured this out. This was like 40 cc's of dead space. Well, in an adult who has a 480 CT tidal volume, that's not really going to cause too much trouble. But if you've got an infant, if you had any sort of dead space like this, it's going to make it very difficult to ventilate the child's lungs. And last, before we leave equipment dead space, we don't think about our anesthesia circuit on our anesthesia machine as contributing to the tidal volume of the child. But the next time you are giving an anesthetic and your patient is on a ventilator, gently wrap your hand around your anesthesia circuit. And what you'll feel is when the bellows comes down and you're giving a breath, that circuit's going to expand a little bit. Again, in an adult, it's an inconsequential amount. But if you're dealing with an infant, it may be significant. And that's why the circuits for little kids are much smaller than adult circuits. So again, watch the chest expand to make sure that what you're delivering to the child is actually ventilating the child. And as we're doing that, we absolutely have to avoid barotrauma. So use a ventilation bag that's the appropriate size. It's a lot easier to judge a 50 milliliter tidal volume if you're using either an infant 250 bag or a 500 milliliter bag than it is a 3-liter bag. And preset the maximum pressure and tidal volume before attaching the child to the circuit. So let me say that again. Preset the maximum pressure and tidal volume before attaching the child to the circuit, and do it for both pressure and volume modes, even if you're only going to use one, and preset it even if you're planning manual ventilation, because trust me, if an emergency arises and you have helpers in the room and there's a lot going on, it's too easy to just throw the switch on the ventilator or having your helper throw the switch on the ventilator. And if you haven't preset all of that, you don't want to discover that you've given a 600 milliliter tidal volume to your infant after it's already been given. Set low, watch the chest rise, adjust up, and always be careful of the pop-off valve. Now, this funky picture over here was actually kind of funny because my colleague and I were testing the circuit for leaks. So we had the circuit obstructed here on its little port. And we got called away out of the room. And when we came back, this was what we found. And the circuit had been left at a 5-liter flow and a pop off of 20. Now, neither one of those volumes sounds terribly dangerous, but with the circuit obstructed, this is what it did to the bag. And so if you had partial airway obstruction, let's say you had a kinked endotracheal tube or partially kinked endotracheal tube in your baby, you don't want to get into a situation where your circuit is overdistended. Trust me, if you get bilateral tension pneumothoraces in a child, it is not fun. Intubation must also take anatomy into account. Straight blades are often easier in children. The larynx is higher in the neck, it's more anterior, and the tongue is relatively larger. And when you're using a curved blade, the tongue tends to have to displace the tongue forward. And in this case, with a higher larynx, a more anterior larynx, and a larger tongue, it's harder to displace that tongue forward. So lifting up the epiglottis tends to work better. Kids have shorter necks. There's a smaller separation of hyoid bone and thyroid cartilage, and all of the structures are more fragile and more easily damaged. Now, in an infant, the rounded occiput tends to affect getting the baby into sniffing position. Like I said, putting a rolled towel underneath the back of the shoulders as opposed to underneath the head tends to work well. But that rounded occiput tends to roll a lot of times. And so in order to keep it stable, you can actually take a small rolled towel and kind of bunch it up on either side. There are small gel rolls that actually don't lift the head up that much, but stabilize the child, or you can actually use one of your helpers to keep it from rolling around. Now, as I said, a curved blade may not be as effective, and it may actually fold the epiglottis downward. And the reason for that is the curved blade relies on being able to lift the hyoepiglottic ligament. And this is a picture of that. This is obviously an autopsy specimen. And here you can see that the curved blade's not on the hyoepiglottic ligament. And here it is. And when it is, the epiglottis lifts. And when it's not, the epiglottis doesn't lift. And this is an adult. And it's all angles. It's basically a pulley system. And so if the larynx is higher in the neck, when you actually pull on the pulley, what will sometimes happen is it will fold the epiglottis down rather than up. And if this is happening, if you're using a curved blade and this is happening, just lift the epiglottis up with your curved blade. Use it like a straight blade. Now, I'm not going to get into a lot of differences with glide scopes, but basically glide scope blades are shaped differently to try to match the anatomy of the child. And sometimes if you're having difficulty seeing, select the next smaller size than recommended for that particular weight child, because sometimes because of that child's anatomy, it will provide you with a better view. And that gets us to, with intubation, cuffed versus uncuffed tubes. Now, in the old days, back when I was first training, we hardly ever used cuffed tubes in children. It was always uncuffed tubes, round peg going into a round hole because the cricoid ring is the smallest diameter. And we did that because in those days, we had low volume, high pressure cuffs, and we were trying to avoid trauma to the trachea and any sort of edema and post-extubation croup. But as we've moved into more modern, high volume, low pressure cuffs, and some of the more recent studies, it's demonstrated that there really isn't much of a difference in trauma between cuffed versus uncuffed tubes. And so we here in the United States have started moving more towards using cuffed tubes than uncuffed tubes. Cuffed tubes have advantages. They're better protection from aspiration. If you start with too small a tube, you don't have to change it in order to be able to ventilate. You can just inflate the cuff. It allows higher ventilation pressures if you have a child who's wheezing or has pneumonia. It allows more accurate tidal volumes because you're not losing volume around the hole. It's more precise monitoring of ventilation, certainly less waste gas contamination for you and your crew. And there's certainly a decreased risk of fire with an ignition source if you were doing a tonsillectomy or some other airway surgery. But cuffs do have disadvantages. The cuff takes up space. You usually have to use an endotracheal tube size at least half a size smaller. Smaller tubes, higher resistance to breathing, easier to plug with secretions, and suctioning them is harder. So use your best judgment. If you have a sick child, are going to have prolonged ventilation, if you have higher airway pressures, an aspiration risk, or a fire risk, consider using a cuffed tube rather than an uncuffed tube. But do, again, even if you're using a high volume, low pressure cuff, be mindful of the pressure that you're putting into that cuff and go for minimum seal. Cricoid pressure can be as valuable in infants and children as it can be in adults, but the larynx is much more easily compressed and distorted. So you have to avoid excessive pressure. And often, especially in a small child, consider using one finger as opposed to two fingers. And just as in the adult, you have to communicate with the helper. Intubation is a team sport. I always tell my students it's not a solo sport. And so good communication is absolutely key, especially if you want somebody to press where you want them to. Check the teeth before and after. Children are constantly losing baby teeth. If a tooth is missing, always recheck to find out where it is. Is it in the airway? Is it in the bed? You don't want that in the patient's lungs. Now, placement of the tube has to be careful to avoid mainstem intubation and unplanned extubation, because the trachea in a child, especially a newborn, is much shorter. In a newborn, you might be dealing with a 2 to 4 centimeter trachea. In an adult, you might be dealing with a 10 to 15 centimeter trachea. And so that means in a newborn, 1 centimeter, so half an inch for me, 1 centimeter might be enough to either extubate the baby or perform a mainstem intubation. And so positioning the tip of the endotracheal tube, mid-trachea, is key. Now, I'm sure you've seen this formula before. If you're dealing with babies, the endotracheal tube size times 3 usually places the tip mid-trachea. And if they're a little bit older, age divided by 2 plus 12 does the same thing. But whether you're using a formula or not, always check the position of the tube. And always check the position of the tube, not only right after you've placed it, but every time you move the baby or the toddler. Because again, a little bit of head motion can be enough to extubate or perform a mainstem intubation. And the mnemonic I usually give my students is the hose follows the nose. So if you put your head down and the nose goes down, the endotracheal tube tip is going to go down. If you put your nose up and look up, the hose goes up and the endotracheal tube can actually come out of the trachea. So every time you move that child significantly, check. Now, if you're taking that child intubated any distance, I always take my airway equipment with me. So I always have, an ambu bag with a mask, and I always have a laryngoscope with another endotracheal tube, because if it comes out in the elevator, you don't want to be in the middle of an emergency with no airway equipment. So avoid mainstem intubation and esophageal intubation and unplanned extubation. Verify correct positioning. Like I said, every time the child is moved, secure it well. Now, there's a real tendency to not tape the tube right where it's exiting the mouth. There's a tendency to put it 1 or 2 centimeters higher. But if you leave a tail like that, the tube will either go in deeper, it will tend to go to where the tape is, or it can flip out more easily. So I always recommend taping it right at the gum line or where it's exiting the lips. monitor end-tidal CO2, and just be aware, the smaller the tube is, the easier for it to kink. And typically where it's going to kink is right back inside the mouth. So be alert to resistance changes and signs of obstruction when you're ventilating. And always be prepared for reintubation. So laryngospasm is very common, unfortunately. And I think part of the reason for that is obviously children have a higher MAC, and we're often intubating them without muscle relaxants. And so we may not be waiting quite long enough to intubate the child. The other period of time that's most likely is extubation, immediately following extubation. So if the child has a significant URI, they're going to have a more irritable upper airway. And we tend to postpone surgery if somebody has a really bad cold for about 2 weeks. If it's elective surgery, obviously, if it's not elective surgery, you can't do that. Now, I always tell folks that, you know, from the time you have a baby until they're about 19 years of age, they always have a runny nose. So it would be almost impossible to find a period of time when a child doesn't have a cold that's either coming or going. And so what do I look for? I look for a chest cold, fever certainly, but if they're coughing anything up, certainly if there's any wheezing, you know, if there's a lot of congestion in the lungs, those are the kids that are really going to be at risk. Never stimulate the airway in stage 2. Now, this sounds like something that we would just automatically avoid, but it's very easy. Let's say you extubate a patient deep. Now your patient is going to go through stage 2 without the endotracheal tube, and maybe you're standing there being very cautious about not stimulating that airway, but my guess is your room crew is going to be taking the monitors off and getting the baby ready or the child ready to move over to another bed to get the child out of the OR. And so that includes everybody not stimulating during stage 2. Keep your room crew apprised of what stage of anesthesia they're in. Don't extubate if the child is actively coughing. In my experience, if the child is actively coughing and you pull that tube out, they're more likely to go into laryngospasm. When they're coughing, they'll almost always stop coughing and you'll at least have a couple of seconds of quiet breathing. That's when you want to pull the tube. Keep the airways clear of secretions, suction the airway before you extubate. Now, intubation, if you have a really high-risk child, you can consider giving a muscle relaxant to avoid it, like a Nectine or something like that. But just bear in mind that if you have a high-risk child, they have a high-risk airway, perhaps you don't want to risk losing their natural muscle tone and therefore losing the airway. And breaking laryngospasm, stop stimulating the vocal cords. Sometimes that'll be enough. Alert your team. Never treat laryngospasm alone. We all have egos, and we all have the tendency to look at a complication like that and just say, you know, if I'm just quiet, it's going to go away and nobody will notice it. But things can go bad so quickly, especially in children, that it's not worth the risk. Just alert your team. Direct all efforts to delivering oxygen. And that means remembering to turn the nitrous oxide off if you're using it. Now, tight oxygen mask, positive pressure, and I think jaw thrust is absolutely key. Now, I can't prove this, but it makes sense to me if you look at this picture of laryngospasm here, that what's happening is the vocal cords are not the only thing that's closed. You've also closed the false cords and all of the periglottic tissues right here. And if you are giving positive pressure, unless there's a chink here, unless there's a way for that air to get underneath and kind of pop open the airway, I don't think positive pressure by itself is going to work very well. But I think if you do a real jaw thrust, that what happens is you're actually pulling the backs of the arytenoids apart a little bit to the extent that you just get an opening. And once you have an opening, you'll get some oxygen in there and it starts to break apart. Now, I've never seen anybody test that or any study, but just anatomically, I think that's why jaw thrust along with positive pressure and a tight mask fit works. But you want to work quickly. You don't want to wait until that child gets bradycardic. So consider a small dose of IV sedative. You can consider a small dose of something like succinylcholine. If you're giving it IV, you really are just breaking laryngospasm. They don't have to be completely paralyzed. If you're giving it IM, obviously that does need to be a larger dose, but you do need to remember in either case that you need to support ventilation until it's recovered. Excuse me. And if you have given neostigmine as a reversal agent, just remember that that means that your succinylcholine is now going to become a longer acting agent, and you're going to need to support ventilation better. Now, once you've broken laryngospasm, you always have to be on the alert for post-obstructive pulmonary edema. Medication error. We don't often think of medication error as a real risk for respiratory failure, but again, like my 2-kilogram child in Hue, Vietnam, a medication error led to a near miss on an airway. And so never give an order without units. If I ask my nurse to give 1, she doesn't know whether it's 1 milligram, 1 milliliter, or 1 liter. Draw up the correct milligram per kilogram dose for a child. And if you don't remember it, look it up. Check the concentration. I don't know about India, but in the United States, especially during the first days of the pandemic, our supply chain was a mess. And our hospitals couldn't really get our drugs very easily. And almost every day, the concentration of what we were using was changing. And so we really had to be mindful of the concentration that we were using. Label syringes. Broslow tape can be very useful, but it can also be misleading because it's in milligrams and we tend to give things in milliliters. And that means math. And anytime there's math, there's the potential for error. So check math with a colleague. And if you're using a pediatric drug calculator, just make sure that the concentrations that the drug calculator uses are the same concentrations as the app that you're using. And then again, this goes for any patient. Always read your labeled syringe before pushing the plunger. I've been doing anesthesia for 42 years. I cannot tell you how many times I've picked up a syringe, gotten ready to give it, and realized that I picked up the wrong one. And if you catch it when it's still in your hand, you haven't caused any problem. Airway management doesn't end in the operating room. You have to be mindful of what's going on in your recovery room and on the wards for each one of your patients. Now, if it's an average patient, I'm sure your recovering room staff is going to be comfortable with that. Your hospital staff is going to be comfortable with that. And if they have a normal airway, all is good. But if you have a complicated child or a child that's at particularly high risk, or they've had a particularly dangerous or unusual surgery for your location, maybe your recovery room staff isn't going to be comfortable with that child. And maybe you're going to have to hang around for a longer period of time to make sure that child is both stable as well as recovered enough for you to leave it. And to just be mindful that you have to think ahead to the next stages that your patient's going to be in, not just the part that you're taking care of at that moment. And that also means that you have to know your limits and your hospital's limits. Now, these are 3 patients I've taken care of. The baby over here has a cystic hygroma, and we did an awake nasal intubation on this baby because we felt that it just wouldn't be safe to intubate this baby asleep. This boy was in the Philippines on on a volunteer trip that I went to, and he had severe mandibular hypoplasia because when he was an infant, he had had an infection of his temporomandibular joint, and that was locked. So not only did he have severe mandibular hypoplasia, he couldn't open his mouth. And so he allowed us to start an IV, and we did an asleep, spontaneously breathing nasal intubation on him. And then this child had epiglottitis, and this was an asleep intubation, making sure that that baby was deeply anesthetized before we tried instrumenting the airway. Now, I'm not going to say that for us, a resident or postgraduate trainee shouldn't be involved in any of these cases. Obviously, I, as a trainee, was involved in cases like this, but it does mean, in my opinion, that you should have the most experienced airway manager right there with you, either doing it with you assisting or immediately available in case there are complications. And if you don't have someone who is experienced in airway management, unless it is a life-threatening emergency, in my opinion, you should try to get one or get that child to a location where they can be better taken care of. Now, sometimes that's not going to be possible and you have to do the best that you can, but maybe that child doesn't need to be, say, intubated. Maybe this child with epiglottitis could be treated with steroids and racemic epinephrine and resolved enough that you can temporize and he doesn't need to be intubated. So just bear in mind that you need to think about your limits. And if there are limits, you need to plan on how to make this procedure the safest for your particular patient. And so hopefully I've made the idea of taking care of children under anesthesia a lot less scary. Oxygenation and ventilation are key. So prepare your equipment, know your anatomy and physiology, and be methodical and gentle. And if you do that, you're not going to hurt the child. Thank you.
I think, Madam Whitten, that I'm just so lost for words. That was a very passionate teaching of from you, and you just taught us through your rich experience. I think postgraduates here, all of you who are here, you should understand she has taken us through the complete spectrum, starting from pre-medication, intubation, interop errors, complication, extubation, and she has completed off including the recovery room. And I think that is she's completed every aspect. So Edward sir, shall we go on to the to Ramesh sir's lecture?
Yes, madam. We will move on to
Shall we?
Yes, yes. Yes,
right.
Madam.
Yes, sir. So a short introduction for Dr. Ramesh sir. He is my teacher, and he's been a very good. He's been our teachers and most of all of us, and he's been practicing exclusive pediatric anesthesia from the year 1990, and he represents India for the children of the World Anesthesia Foundation. He has delivered 14 orations. I think it must be more than that. He's a founder member of the All India Difficult Airway Association, and his main area of interest is pediatric airway and pediatric airway surgeries. Over to you, Dr. Ramesh sir. We are waiting to hear from you.
I'll just share my screen. Good morning, ladies and gentlemen. Are you able to hear me? Everything is all right?
Yes, sir.
Okay.
Yes, sir.
I think Dr. Chris Whitten has made less scary for anesthetic children. Probably after my lecture, it will be, I will make more scary for anesthetic children. And it's good she has covered all in basics of physics, anatomy, physiology and everything. And probably this is a more clinical complement for all her talks. But there are certain controversies which I heard from her, but this is all my own judgment. It may be wrong. Having said that, today I have mixed feelings in me. One is that I am really proud to be invited by Dr. Edward Johnson, and if I am not wrong, it is the top 10 blocks of anesthesia in all over the world, and I am in one of the part of giving a lecture on online anesthesia for the postgraduates teaching today. Second, I am a bit nervous of the people who have written a lot of books, especially very simple basic books by Dr. Chris Whitten, and this is the one which I got. This book, Anyone Can Intubate, I got in 2003, and I think the next couple of editions have come already, but it is a very practical step by step guide. The second book, Pediatric Airway Management, I have not read, but I am sure I will read soon. And not only that, the direct message was given by Edward Johnson in the middle and saying around 750 watching the live tube. I am just, he is probably just warning, please do your job properly. Before I come into it, I just want to talk about little quotable quotes on the airway management. Airway management defines as an anesthetist. This is by Rosen said, there is one skill above all else that an anesthetist is expected to exhibit, and that is to maintain the airway impeccably. The case by Jonathan Benham is one of the top 10 anesthesiologists in the world. The most compelling educational effort for the anesthesia community should be reduce the frequency and severity of complications related to managing airway. I am sure all will agree with that. The third, that Whitten showed a lot of equipments, but the success perhaps relies on the operator's experience, practice and skill than the devices themselves. Having a device is not good, you must know how to use the device properly. Atul Gawande from Harvard said, progress in medicine will not be made through improved technology, but rather through improved application of current knowledge and activity, in short, doing it better. The only three important aspects in anesthesia in children are: number 1, airway; number 2, please think; the second is the airway, and the third is the airway. I think that is the most important. If you maintain the airway, none of the children will die. So, coming to my topic, pediatric airway management, art versus science. Is it a art or is it a science? I think I modified the definition. The practice of pediatric airway is an art, but based on science. So, what is an art? Art is a skill or special ability at doing a specific thing, typically acquired by experience. This is what the Oxford English Dictionary said. So, everyone will agree that the pediatric airway is an art. Having said that, by about 40 minutes, my roadmap of the talk will be art of opening the airway, the art of mask ventilation, the art of supraglottic airway insertion, art of oral intubation, art of nasal intubation, art of oxygenation, 5 devices, the art of extubation, the art of video laryngoscopy, and the real art of airway management, some cases which we modified, so that how you can modify the anesthetic in children. I am not going to in detail, but it is going to be a clinical case scenarios. Art of opening the airway. It has been very clearly told the 3 things. One is a head tilt, and open the mouth and give a jaw thrust. But this is what the book says, but it is not very easy to do that in children. This is an anatomical airway obstruction. As you see here, it is getting obstructed. If you leave the obstruction for a go long, it will cause post obstructive pulmonary edema. So, you need to leave the obstruction. For that, you need a jaw thrust. For that, we just have to, you see here, open the mouth, head tilt, and just lift the jaw, the obstruction is relieved. There is a simple maneuver, but believe me, if you don't know how to use it, you may cause more obstruction. For example, people is usually they put the angle of the mandible and lift it. If you lift it, it will close the mouth. You must lift the head of the mandible. Please remember this. I will show you. See, this is actually angle of the mandible. Don't lift the angle of the mandible. You have to lift the head of the mandible from here. So, this I am going to show you a video. You see, if you just put in the angle of the mandible, it lifts the jaw, but it will close the mouth. But if you lift the head of the mandible, it lifts the jaw and it will open the mouth. This is a very important step you must realize when you are opening the jaw. Many of the adult anesthesiologists, if they come to us for fellowship or something like that, they cause more obstruction because they have to lift only the head, not the angle of the mandible. So coming to the art of mask ventilation, I think during the 1-year fellowship, if I have taught them how to do mask ventilation in children, I have done my job. This is what I think that Whitten has told in a diagrammatic fashion, but I am showing in a clinical fashion. This is how there should not, when you are holding a mask, there should never be a grease. When there should be never be a grease, and there will be not flexed. It should always be extended, and there should never be a grease. I will show you a good mask ventilation here. This is how it is. Don't press the soft tissue and just lift the mandible, and you must be able to ventilate nicely. The chest to expand, not the abdomen should distend. So when you are not doing the mask ventilation properly, the abdomen will distend. You know, the children are diaphragmatic breathers, and it has been splintered. You give air into the stomach, it will splint much more. Not only that, there will be a lot of food in the stomach, it will vomit and it will aspirate. So if you want to put a mask ventilation and the abdomen is distended, please put an nasogastric tube, deflate it. This is an experiment done by Kester Brown from Australia about 35 years ago. So when you have pressure with the abdominal gas, the volume is FRC is very less. When you put the nasogastric tube and deflate, the FRC is almost double when you deflate the stomach. Coming to the Rendell-Becker-Susak mask, it was introduced in 1961. I thought that was the game changer in pediatric anesthesia. So what happening is there are a lot of things just come 0, 1, 2 because of lightweight and dead space is less easy to hold, but it is not true, because holding with when there is a difficult airway, with the help of the holding with the mask is very difficult. The fit may not be all right. If you put an oral airway like this, then Rendell-Becker mask is not fit properly. I think the better mask is actually this is a bubble mask. The silicone mask comes in 0, 1, 2 and 3 sizes, and that will easily shape according to the face and the mouth and the nose, and not only that, it's transparent. You can see any secretions or vomiting through that. It's a beautiful mask, and Rendell-Becker mask not very useful at all. Okay, I told you how to open it, I told you how to mask ventilation. I will come to the art of insertion of supraglottic airway devices. The first generation supraglottic airway device, I think this should never be used and it should be banned. It is not that when Orchibrain used, it was really a boon for the airway management, but especially in children, when you put a first generation supraglottic airway device, the abdomen get distended, it will not fit properly. So I think second generation supraglottic device, either a Procel or iGel or a Blockbuster, are quite good enough to do that. I am a little proponent of Procel LMA, it fits it very well, but you can use anything, but you should not use a first generation supraglottic airway device. So how will you insert? This is actually she is a girl, she is a resident who is from Kerala, who has come for us, and she was doing a supraglottic airway device which is not right. I just took a video in that. You see, she is extending it and somehow trying to push it inside. See, when you push it like that, the tongue will go inside, it will get obstructed, it cannot do all right. So the best thing is how to do then. How to do the properly, I just want to show you.
The art of airway management children in the month end.
Wow.
So that's how you have to do. Nicely extend smoothly, extend little bit, open the mouth completely, take the LMA on your right hand, and then like a laryngoscopy blade from the lateral end, just put in a single shot. You just have to put it like that, and then it's inserted and hold it. When you don't hold it, the children, the tongue, it will bring out the LMA outside. So you must hold it and fix it nicely. See, this not only putting the LMA, but taking out the LMA is also very important. The incidence of laryngospasm with LMA and the endotracheal tube are more or less the same, and what are the precautions you are following with the endotracheal tube, you should follow also for the LMA. This is how we should extubate. I cut off everything, use oxygen, little bit of sevoflurane. It's better to do deep extubation. See, you do like this, ventilate. And suctioning the gastric port, so the stomach, and ventilate nicely, remove the plaster slowly. So when you remove the sticking plaster, if there is no stimulus, you can bring it out. You can see slowly, you can bring it out like that, and you can extubate without any problem under deep extubation. You can see here, and then they give the reversal and extubate, and extubate should be deep enough. See, when extubate deep, the child is breathing quite all right, smooth respiration, no problem. I don't mind the child is deep and the child should not get obstructed. The second, I like Blockbuster also, very easy to insert, and it's a second generation supraglottic airway device, is easy to insert, and even that with a blindly you can even put the endotracheal tube through that without a fiber optic scope. You just have to put it like this and then it is inside. So the Blockbuster is also a very good supraglottic airway device. I like RQ. RQ actually is RQ, and I know Sim Jagannathan, he is from Chicago, he is a good friend of mine from Chennai, he is a big man in the airway, and anything with RQ in children, it is nothing like Jagannath. Sim Jagannath and RQ, more or less the name is same together. So the best part of the airway, this RQ, is that the connector can be removed, and not only that, 0.5 size LMA is available in RQ, where you can use it even less than 5 kilo baby with the help of the 0.5. I'll just show you how RQ is being inserted. You can see here, just have to put the RQ inside, it made nicely. This is a child which is about 2.8 kilo, and you can fix it nicely, and then when you fix it nicely through the RQ, we can also put a fiber optic intubation like this. Once RQ is put inside, you can remove the connector, and then through that you can put an endotracheal tube. It's a really, RQ is one of the very good one. Two important advantage: one is 0.5 is available, the second fiber optic intubation is much easier with the RQ. Well, coming to the art of oral intubation, I am sure you all know goals of laryngoscopy. What you want to see is like this, but the problem is that the cords are here, but what we are here is in the mouth, and what we need is, we need to do a curvature and put the endotracheal tube. This is the goal of the direct laryngoscopy. So you have to get rid of the corner. So you need a straight line. So it has been that told. This is a lot of changes happen in this, but the basics are always basics. Oral axis, pharyngeal axis, and laryngeal axis. There are a lot of controversy in this 3 axis these days, but I think to understand the direct laryngoscopy, it gives you a very good idea. So all the 3 axes should be in similar lines at more or less a straight line to intubate. So infant, you put a little bit of a, no need for this, but if you want to put it, you can little bit of a shoulder pack to stabilize the neck and the shoulder. In a smaller child, you don't need anything. In the older children, a small cloth under the head will be very good. This is just put a small cloth under the shoulder and the head to stabilize. You can put a head ring or a cloth folded like this. See, when you are going to mask ventilation, you should not be over flexed. You must always extend it. Similar when you do the same position if you want to intubate. If you are flexed, your laryngoscopy blade, you may not be difficult to insert. When you extend it, it is easy to do that. Our intubation mantra is, the best friend for intubation is epiglottis. The best enemy for intubation is the tongue. So if you want intubation, what you should do is, you should see the epiglottis, but you should not see the tongue. So your aim is not to see the vocal cords. You see the epiglottis, behind the epiglottis there is a cords. So the best thing is push the tongue on one side, see the epiglottis, lift it, then intubate. It's not very difficult. So we should not do. You can see here. She's trying to intubate. With the laryngoscope, she's opening the mouth and she's searching for so many things. You cannot search there. See here, there, and all this. Don't search for that. I think this is very difficult and you cannot do that. So you cannot search like this to put the tube. What you should do is, you should put laryngoscope slowly and go to the left hand corner, push the tongue to the left side with the help of a little finger on the same, easy to do in a small children, and then you just see the larynx here, laryngeal view. Once, don't put in the straight and try to put into that like to killing somebody. You go nicely from the side. What you should do is, you should go from the side, slowly intubate. You should do it in this style like that. When you do like this, and you can put like without any problem. It's an art to intubate really. Nobody feel that you are intubating and there's a big strain on that. In this, I have a little. See, what I'm telling this one is that when you're doing a straight blade, what Dr. Whitten said is very true, that the epiglottis gets unfolded when you curved blade. But what happens is, when you use a straight blade, the tongue will come on both sides. When the tongue comes, you will see the vocal cord, but you don't have enough space to intubate. So the thing is that, my thing, it's not that it is to be advised, but I feel that curved blade can be used as a straight blade, so that the push the tongue to the left side. You can also lift the epiglottis, and easy to intubate with a curved blade than the straight blade. Coming to the art of nasal intubation, this is how you should do it. Actually, you must put nicely, you must lubricate. This is very, very important. Lubrication is the mode. In a child, if you don't lubricate well, then there will be adenoids bleeding and a lot of things will be easy. It may not be very easy to intubate. See, this is how, see, people, because the nose is like this, they will put horizontally and try to put like that. You cannot put it. What you should do is put it vertically down, and then slowly you put it like this, so that it will pass over the nasal septum into the pharynx. You can go slowly till you lose the loss of resistance. Once the loss of resistance lost, just leave it like that. Once the loss of resistance is not there, you can just putting a video laryngoscope just to show you. When you do like this, what you do is that, when you do like this, you just have to put the Meggle's forceps. Don't catch the tip of the endotracheal tube in the Meggle's forceps, because you may not be able to insert it. You must do a little more distally, and then don't push it like that. You should put only the, guide the tip of the endotracheal tube into the vocal cord, then do some flexion, and then it will go smoothly without any problem. Don't try to Meggle's forceps, don't try to put the tube into the vocal cords. The vocal cords just guide only to up to beyond the tip, goes beyond the vocal cords. Once it has gone beyond the vocal cords, take the Meggle's forceps and then you flex the neck and insert smoothly. This is another one which I just want to show you, small, which is done. It's a big swelling which is happening here. I thought inside there is no swelling, and we found to put a laryngoscope. I found a big cystic fibrosis goes straight and also obstructing the vocal cords. That is about in 1992. So I thought, why don't you do two laryngoscopes? One to lift it, one is to pull the tongue, good lighting and easy to put the tube. This is in 1992, where there is no video laryngoscope, nothing was available. So this is a two-way laryngoscope. If there is available, two laryngoscope is also as an art to intubate. So this is how I intubated in 1992. Coming to the laryngoscopy, see the laryngoscopy is to retract the tongue, not to extract the teeth. This is how you must do. Don't do it anchoring here. So what you should do is, you push it like this with the help of the tongue, little finger, you push it. There is a good space here. Go from the side. How to do with a cleft lip, bilateral cleft lip like this. See, I am going to show you this, how to do a bilateral cleft lip, how to intubate. See, what happens is that if you do like this, actually the flange goes into the cleft and you don't have enough space, you cannot do it. So what you should do is, this is probably we call it lateral intubation or lateral laryngoscopy, and go to the flange to the lateral side on the left side. Then you have got enough space here. When there is enough space here, somebody has to pull the cheek will obstruct, go with the endotracheal tube from the right side, like the same like in any endotracheal tube, and then fix it. So this is not, people think the cleft lip is very difficult to intubate. It is not difficult if you know how to intubate. The common error of the laryngoscopy blade is that when the junior people does, the laryngoscopy is pushed deep, then they will say I am not able to see, I am not able to see. So when you do in a small child, I am just doing a video laryngoscopy, I am not doing everything with the video laryngoscopy, just to demonstrate I just took the video laryngoscopy. This is actually very deep. Then they look at it and they say it is an vocal cords, then they intubate. This is not the vocal cord, this is esophagus. So if you come little bit above, you can see the arytenoid, and then you can see this one, and then you can see the larynx. Little more up, a little more, you can see the vocal cords and the epiglottis. That's why you should not go very deep. Coming to the art of oxygenation. See, I am sure everybody would have the concept what is called the pre-oxygenation. Now there is concept called the continuous oxygenation. You oxygenate pre-op, intra-op, and during the intubation you must oxygenate. This is what is called continuous oxygenation. Dr. Fierjo is in Philadelphia. Now he is a good friend of Sim Jagannathan, and they wrote a very good book on pediatric airway management. He is now at Boston Children's Hospital, and he had come here and met him at Boston as well, and very fantastic speaker is Fierjo. What did he say? He said, it's a very beautiful example. He says, there's a parachute. When you're jumping from a plane, you have a parachute. The parachute is not from the start. You have to continuously till you land, you have the parachute. You just imagine the parachute only during the start of the jumping. In the middle you lose the parachute, then you are lost. So this is the same concept for oxygenation also. You must do continuous oxygenation during the mask ventilation into laryngoscopy intubation. How do you do? There are many ways. Like usually you can use HFNC, high frequency oxygen, what we do in a neonate, or you can use a nasotracheal tube or usual nasal cannula which you are using for any other patient with 4 liters or 5 liters of flow. Continuously you can oxygenate, you can intubate, there is no deoxygenation. There is a beautiful paper by in British Journal of Anesthesia 2016 by Steiner. If you don't give supplement oxygen during intubation, there is a rapid desaturation. But if you give supplement oxygen, there is definitely increase in the timing to intubate. Okay. You know that if you are going to get into the plane, you have to also get out of the plane. So getting in and you must also get out. So intubation is not the only one, you must have to take out the tube, and that is an art. I feel extubation is an art than the intubation. So I am going to show you a small video of how we extubate. This is the child with oxygen with the sevoflurane. As you see here is a spontaneously breathing patient. This is still I use a Jackson-Rees circuit because I am still a old man still using a Jackson-Rees circuit. During induction and intubation, the remaining for the maintenance I use a closed circuit. So this is how you use breathing spontaneously. I remove the plaster. There is no response to that stimulus. So there is no response to the stimulus, and the spontaneously respirate breathing, and you can slowly extubate. Don't take out the tube like that in stale. You have to do slowly. You remove the tube slowly. You see here slow intubation, extubation, and there is no stimulus. Breathing spontaneously and slowly take it out. As you can see here, slowly take it out, don't take it immediately. Then as sevoflurane is even cut off now at this particular time, and then you can extubate, and then you can see all the mask, and they are okay with that. I think this is a beautiful deep extubation very useful, but deep extubation should be done by an experienced person. But in a preterm or a newborn, must be fully extubate, no de-extubation. Either you take the bum up or open the eyes completely like this. The child should open the eyes completely, or you must lift the bum. If they are breathing or coughing, the newborns will cheat you. So don't extubate till they open the eyes and lift the bum. Okay. Coming to the art of video laryngoscopy. Nowadays what happened, there is a pediatric difficult registry, and all of them in the same registry, that number of attempts have reduced, then the intubation injuries are much less. So they all say that first attempt should be a video laryngoscopy, but it's really very difficult. I don't, even in the US it's very difficult, in India it's very difficult to buy, it's very expensive to start as a first attempt video laryngoscopy, it will take a long time. So what is important, a lot of laryngoscope is available, but what is the heart? First, when you are putting the laryngoscope, you must be put this is the 4 steps of video laryngoscope. First you put into the mouth, you look into the mouth. Once you put in the laryngoscopy, then you look at the screen, see the vocal cords. Then we are putting the tube, you look into the mouth. When it is going, then look into the screen. In the mouth, at the screen, in the mouth, at the screen. I think that's a very important. I just conclude with some cases where the art of airway management helps. This is the child with a small ranula, as you see here, and it looks very simple, but the child is not cooperating. What we should do here is that I put a jelly into this, and then after putting the jelly, you can see here, you just put the endotracheal tube through the right nostril like a nasopharyngeal airway. Actually this is all it is. Then you put the nasopharyngeal airway, then you can fix it nicely, and then because you are giving only the sevoflurane, little the propofol, what you do is you can even get the ETCO2 trace. Then give the local blocks, either you can give a submental block both sides, and then it is excised, and then the child is all right. Then the suture removal, the lip, cleft lip, the suture removal, the cleft lip, same with the nasopharyngeal airway with the sevoflurane, and then we can do the suture removal without even having an IV line. For gastroscope, what you do is with the gastroscope, with a small mask, put like a nasal mask, and continuous spontaneous respiration, you can use a gastroscope. Come into all the difficult airways like that, there I remember you need 5 devices. For oxygenation, you need a second generation supraglottic airways. If introduction is a problem, you need fiber optic. If ventilation is a problem, get a video laryngoscope. If you are seeing the larynx, you are not able to intubate, the best is a FOA intubating catheter. After a difficult airway you intubate, if you want to extubate, think of an extubation with the exchange catheter. But every step, please remember, in a NAP4 from UK has really showed all the accidents are preventable if the capnography would have been used. I think if all the steps, you must have a capnography. And very proved, complications are directly proportional to the number of attempts. So if you finally, this is a small problem, repeated attempts will cause a big problem. So this is a small edema, keep on trying, it will become a granuloma, again keep on trying, at the end it will cause a subglottic stenosis. So reduce the number of attempts in a small children. So finally, and remember, the aim is adequate oxygenation, not plastic in the airway at any cost. Don't think that you must put the tube, no need. As long as you can mask ventilate and deflate the stomach with an anaesthetic tube, you can ventilate for some time till the expert comes or with the video laryngoscope. Don't try to put the tube many times and cause laryngeal damage. I think you listened to almost an hour of my lecture. All will agree with me that the practice of pediatric airway is an art based on science. Really? Yes. Thank you.
Thank you, sir, for a wonderful lecture. Gomathy, madam.
Yeah, thank you so much. I wanted to say that too. Both the speakers had shared beautiful PowerPoint slides, madam with her illustration and sir with his excellent videos and I think he's taken us to his theater directly. So a couple of questions for both of you. I would like to start with Madam Whitten. In your experience, what would be the time of or duration of pre-oxygenation in a pediatric patient, both for emergency and elective? What would be the approximate time duration that you would pre-oxygenate a child?
Well, I usually like to pre-oxygenate an average child about at least a minute, sometimes 2 while I'm putting the monitors on. Now, obviously, that's going to depend on how cooperative the child is. If we can make it a game and blowing in and out of the mask, that usually works pretty well. If you have a 3-year-old and it's taking 4 of you to hold the child down, then pre-oxygenation is going to be a little bit more problematic, and you're more likely to do pre-oxygenation once the child is induced before you actually then go ahead and do the intubation. In an emergency, again, I'm going to try to pre-oxygenate to the best of my ability. And the steps that Dr. Ramesh was saying, using nasal cannula and other means to continuously insufflate oxygen, even once the child has lost consciousness, and you're doing visualizations, are really good tricks and really do help to prolong the period before their oxygenation.
Yeah, absolutely. Sir has taught us continuous oxygenation. And Madam, you say the same too. So coming to the next question, I'd like to put this across to Ramesh, sir. Sir, how do you actually do SIBO induction? Can you just take us step by step? Sevoflurane induction.
Yeah, I think this is very clear. This is people. I just wanted to give you a very important information that the people think that the pediatric children should not cry during induction and all. Please remember, there are 2 things. What is, I am sure Dr. Whitten will agree with me, there's one is what is called as a safe and what is called ideal. There are 2 things in that. The safe, if you are a very experienced anesthesiologist and if you have 2 people who can help you out, then think of a inhalational induction. If you are alone, please do not do it, and you are not an experienced anesthesiologist. This has been actually, I remember the sentence given by Frederick Berry. I think the Frederick Berry is a very senior anesthesiologist who is a Smith's award winner also. He died about a week ago because he died a week ago. One of the very efficient, very good teacher. In his book, he has said the experienced people do inhalational induction and inexperienced people do an IV induction. Please think that means that the safest IV induction and inhalational induction in experienced people. I think ideal don't, because somebody thinks the pediatric anesthesia means no pain, you should have SIBO inductions, and in the middle you lose your airway, then you are in trouble. So I think that's a very, very important. So what I feel is that, and second is that the don't think that sevoflurane is a very safe. Sevoflurane is not very safe. If you got 8% in a small baby, it is equivalent to 5% of halothane. Please remember, they think that sevoflurane of 8% is safer. No, it is not the same. So it is actually what they would discuss only the percentage of dial setting, but they have not actually compared the MAC value of both sevoflurane and halothane. So if you want to do halothane sevoflurane induction with a single person, you go slowly. Don't with nitrous oxide. Sevoflurane with oxygen is a good induction, and go with 1 liter, then 2 liter, the child will move. When it's actually, it is similar to ether. It is not a very smooth induction. With the halothane, it's a very smooth induction. So what with the sevoflurane, with couple of seconds, the child will move. So you are actually tempted to increase it to 8%. Don't do that. Do it for some more time, 2-3%, it will quieten down. So don't increase more than 2-3%. Take some more time and oxygenate, and this itself is a pre-oxygenation. So this is 100% oxygen for some time, and hold the mask and get the line. I think that particular time If a person is not able to hold the mask properly, then the child will get to obstructed. I think this is a very, very important lesson, that you must move slowly at 2%, and the person is holding a mask should be an expert, or taking a line should be an expert. Then only you can do an IV CO flow reduction. Couple of times I have seen people have put 8% and keep on tying IV line. I found that pulse is not there. So please remember that when you are induction, you must always watch your pulse and your saturation, BP, everything should be there. You must be very, very careful. So what I do is that I do with 1%, then 2%, little more time. So with 2%, little more time, and ask the expert to hold the mask and then put the line fast. I think that most of the time I have a fellow, but if I don't have fellow, I still use an IV induction. Little bit of a hemlock cream before that.
Okay, so it's slow and steady wins the race, and it's 2 people, and we should be very, very careful. We shouldn't rush it up too much, isn't it?
Yeah.
Got it, sir. Got it, sir. My next question will be
I think
to Madam Whitten.
Whitten wants to comment on that.
No,
Yeah,
I just wanted to say that I totally agree with you, and especially about the fact that you have to be careful about high concentrations of sevoflurane and halothane, because as I was saying, the cardiovascular system is immature, and the ventricles and the sympathetic nervous system are not capable of really mounting a large response. And so they're much more likely to get hypotensive quickly when you depress the heart, as any of the inhalational agents will do. And so slow and steady is absolutely the way to go.
So, Madam Whitten, this will be my next question to you. This was from one of our viewers. He has asked, like, won't mask induction be more of a nightmare to children? Like, our intention is not to scare a child, isn't it? So when you try to mask induce a child, probably would see, well, won't the child get more scared? How do you do it?
I usually try to make it a game, and obviously if you're dealing with a 2-year-old, sometimes it works better than others, but I tell stories, I sing songs. In the United States, it's, at least before the pandemic, it was not uncommon to occasionally bring a parent into the room for induction, although obviously that has potential problems associated with it as well. And we were selective about which children we did that in, and which parents we used for that. But basically, I think that if you're gentle, and the child is sitting and you're holding the mask, maybe not squashed against the face, but lightly against the face, that you can do a relatively gentle, slow induction with a mask that's less traumatic than trying to wrestle an IV into a child. And it really depends on the child. If it's healthy, if the child is healthy, either way can be safely done. If you have a child that's going to decompensate, if they really start crying or they've got croup, then that's a child that we're going to be a little bit more likely to try to minimize and basically choose which direction we think will work best for that particular child. But it can be done. Like I said, I sing, I tell stories, I hold them on my lap. I may not have a tight mask seal to begin with, which doesn't make our contamination control people very happy, but it can be done.
So the art is being gentle, and you have to have a good rapport and sync with the child and his or her parent too. So
correct.
Yeah,
yes.
that's yeah, I got it. The next question will be to both of you. I'd like both of you to answer. We'll go with Dr. Ramesh sir first. This is a question from Dr. Naresh, one of our viewers, and he wanted to know what are the sedatives that are best suited for small for date babies less than 60 weeks post-conceptual age, and is Dexmed useful in such babies? So we'll go with Dr. Ramesh sir first, and followed by Madam Whitten. Ramesh sir?
Yeah, this is actually very I think is a senior, Dr. Naresh Paliwal is a senior person from Nagpur, but I just want to tell you less than 60 weeks preterm. Actually, this is a very, very important place where we avoid as much as possible or more or less no sedatives or narcotics. They are very clear. But if they do a narcotic or sedative, the child has to go back to the neonatal intensive care unit. The very NICU has to be done with this is a preterm, and the preterm is known for a post-operative apnea. And now the things are such that to avoid general anesthesia, give regional, either spinal or a caudal, and do the whatever you need for surgery. And if you need a major surgery, ileal atresia or something like that for intubation, then child will be intubated went to the in the NICU and give a narcotic infusion. But in outpatient, I will not agree to give any sedative, and especially Dexmed. See, Dexmed in a neonate is as an outpatient. I think it is not very well studied in a neonate, and Dexmed with neonate will cause more of sedation, little bit of definitely bradycardia. So Dexmed can be given only in an inpatient, and if you are going to NICU, and there are some reports of Dexmed in a post cardiac surgery in a neonate, some of them, and it is okay, but in case it is being used in an NICU, I still feel that I still feel that morphine is the best, because fentanyl is not very well studied. Some of the neonates, if you give 1 microgram fentanyl, they don't sleep. Sometimes some of the neonates give 0.5 micrograms fentanyl, they get apneic. So I think fentanyl is not very well studied in neonate. Morphine is very well studied. I think if you want to give morphine, but if you want to give pain relief, you can give ibugesic, or you can give a paracetamol. But no, don't sedate the child at any cost for a less than 60 weeks unless the child is going to critical care unit, not in the daycare or in a non-pediatric hospital.
Yeah, Madam, your take on this?
I would agree with all of that. We rely on acetaminophen and for outpatients ibuprofen, and basically try to avoid narcotics unless they're actually going to be admitted and in an observation unit. And we use a lot of regional anesthesia and local anesthesia for those children. You do have to be mindful of the total dose of local anesthetic. So you have to work with your surgeon and make sure that you're doing all the safe calculations. But yes, we would not really be happy giving a sedative to especially an outpatient child like that.
Okay. Okay. Thank you so much. Another question which we had was, did you ever, both of you actually, did you ever tackle a very resistant laryngospasm in your experience? A laryngospasm which would not go away. Did you ever encounter such an experience? And how did you manage such a case? Madam, first?
Absolutely. I think all of us in our careers will have a patient like that. If it doesn't break with positive pressure, then my go-to is to start with some IV sedation, such as a small dose of propofol or something like that, to see if that will break. But if it won't break with that and positive pressure and trying to deepen the anesthetic with the gas, then I go to whichever muscle relaxant seems most useful at the time. It's usually a small dose of anectine. And again, like I said, if you're in a bad situation and you've reversed that child with neostigmine or with tensilon, then you've just bought a more prolonged ventilation support, and you just have to manage the airway appropriately. And it depends. If it's the beginning of the case, obviously you're going to be placing probably an endotracheal tube rather than continuing with an LMA or with a mask procedure if it was that bad, a laryngospasm. If it's the end of the case, then you're going to more slowly wake that child up and make sure that your secretions are taken care of so that you don't get into that situation again once your sedatives and your muscle relaxant, if you've used that, have worn off.
Okay. Ramesh, sir?
Actually, if you are not able to, there is no such thing called resistant laryngospasm. If you are not able to relieve with the muscle relaxants, ventilation, that means it is not laryngospasm, something else. So I think that's what it is. There is no sorry Dr. Gomathy, I think that's how it is. There is no resistant. See, I am little going to be again not with Dr. Whitten. I am going to have some controversy in this particular topic. That is actually, I feel that if you find there is a laryngospasm, my take home is that don't give little of propofol, then little of sedative, then little of sevoflurane, then ventilate. So you are losing time. So if you find that is going to have some time, please if you give little propofol, give the relaxant initially and relax it, because you want the child to be taken off early than to wait for some more time and the resident is not able to follow, not able to ventilate, then wait, then you give muscle relaxants. I feel that succinylcholine, you don't use it very often, but the succinylcholine should be on the table before you start the pediatric case. I think they are very clear with that. So succinylcholine should be diluted and kept it. There is no actually the low dose. I believe that instead of giving 0.3, 0.5 milligram per kilo, I give 1 milligram per kilo of succinyl, because I want it to act, because that's very clear about it. So if it's 10 kilo baby, I give 10 milligram, relieve the spasm, ventilate. You don't have to put the endotracheal tube. You can ventilate with a mask, then wait for some time, it will breathe already. I am little of propofol, muscle relaxants early is my choice, than give a little bit of relaxant, sedative and more. This is my way of thinking.
So shall we take it as doing a systematic and complete study, I mean, taking the baby to a deeper plane, so that anything superficial or any stress might trigger laryngospasm? Am I correct, sir? You mean to say we need to give the appropriate dose, anesthetic dose, and get the appropriate anesthesia action also, so that any stress or stimuli will avoid laryngospasm, isn't it?
That's fine. That's fine. I think that's okay.
Yeah. So thank you. Our next question will be from Dr. Muthukumar. He has asked us, how do you actually, Madam Whitten, madam, how do you select an oral or nasal airway in preterms? You have already covered it in your PowerPoint, but he still asked us that question. And he's also asked us, do you keep them when they breathe? How do you keep them when they are breathing spontaneously? For example, an oral airway and the baby is breathing spontaneously. How do you keep it? Do you remove it immediately, or will we still wait for the baby to recover completely?
In terms of the question, I believe is about selection of size in very small infants.
Yes.
I would use the same technique. I would actually hold the airway up against the side of the baby's face and compare it to the angle of the jaw, because you can actually see. You can actually visualize where it's going to lay inside the baby's mouth. I'd be much more likely to use an oral airway in a very small infant than a nasal airway. Although I certainly have used nasal airways in selected infants when I needed one. And again, it's the distance from the nares to either the angle of the jaw or the earlobe. As estimating of length. You want to make sure if you're using a nasal airway in a small child that it's not so large that it's blanching the skin around the nares, because obviously any sort of pressure like that is impairing blood flow to that area. And so that would imply that it's much too large for that child. But again, I'm more likely to be using an oral airway than a nasal airway. And I tend to leave them in if the child's waking up until they actually start to open their eyes and react before I take it out.
Thank you, madam. The next question is, have you ever encountered a cannot intubate, cannot ventilate scenario in pediatric patients? And what would be the ideal front of neck access, which is advisable in a cricothyrotomy or a tracheostomy? In that case, supposing it's a cannot intubate, cannot ventilate scenario, where you don't have time for FOB and the baby is in too much of respiratory distress, you need to secure the airway. through a front of neck axis, what would be the ideal landmark for a cricothyrotomy or a tracheostomy?
Well, fortunately, although I have had can't intubate, can't ventilate, well, actually, we did have one can't intubate, can't ventilate scenario where I went in to help one of my colleagues, and fortunately, we were able to place a laryngeal mask airway. And I think a lot of times, even though we're much more frequently using a supraglottic airway as an emergency airway in an adult, we're less likely to think of that as a rescue airway in an infant. And I think that we should be thinking about that. And when I'm doing a very small child, I always have a supraglottic airway there that's the appropriate size for that child, just in case. But just in terms of landmarks, you're still trying to find the cricothyroid membrane.
Cricothyroid.
Yeah, the cricothyroid membrane. And if it's a very small child, you can do a needle cricothyroidotomy and grab the jet ventilator that we have in our suite and do ventilation that way. Fortunately, I've never had to do that. Doing a full cricothyrotomy in a child and inserting an endotracheal tube is doable. I've just not done that. Dr. Ramesh, have you ever had to take care of that situation?
Ramesh, sir?
Yeah, I did all these things only in the workshops. See, cricothyrotomy and mannequins and all the phantoms and models, but fortunately I didn't have any opportunity to do on the live children. So I think this is a very, very important that this is my lesson, that all easy to learn and easy to read. And the cricothyrotomy, this cricothyroid membrane, even up to 1 year is only 2 millimeter. Actually, we are doing it egotracheal resection when I take a lot of measurements. I found only 2 mm. In 2 mm, where the question of putting a cricothyrotomy puncture, all this thing, I think that's probably out of question. But I had one case which was a mediastinal tumor where we had little sedation, we got into problems, we can't ventilate, we can't intubate. The Andy at that particular time is a rigid bronchoscope. So you just put in a rigid bronchoscope inside the trachea and try to ventilate, and easier to ventilate. I think all the anesthesiologists should learn how to use a rigid bronchoscope, because that will put in the trachea and you can ventilate. The second, I feel the only option if you are going to do is better to do a formal tracheostomy than to do a cricothyroid puncture with the needle, because if a needle with the millimeter of the trachea is only about 3 to 4 mm and you put the needle, it will, in the posterior puncture is being done, it's not very easy to ventilate. But I think you can call the ENT at the earliest and do a tracheostomy. If you're not able to do a proper tracheostomy, you just put a hole and put an endotracheal tube into that. I think that is the more safest. Don't do a cricothyrotomy. It has been told, it has been taught, a lot of research has been done, but practically I feel taking the knife is a very, very fearful at that newborn period. I think it's very, very difficult to do that.
Okay. I think that was a very, very, very clear answer to all the viewers out here. Thank you so much, sir. And a question on extubation. We'll take it from Ramesh sir first before going to madam. This was asked by Dr. Jamal Kazim, and I think he is sharing his experience. He says a 4 kg baby who had an anticipated difficult intubation, they had multiple attempts in intubation. As you had rightly pointed out in your slide, smaller baby, more attempts, more complications, isn't it? So I think his question is around that. So it was a 4 kg baby, anticipated difficult intubation, and after multiple repeated attempts, this patient ended up with air emphysema, subcutaneous emphysema, mediastinal emphysema. What would you have done in such a scenario?
Yes, extubated, or before extubation itself we created, I don't know.
I presume it's before intubation, because that was all he had written. I presume it's before intubation. How would, if that was the state and the baby is in emphysema now, how would we handle it?
No. See, this is a very situation. There's a trauma during intubation, and there's all surgical emphysema. That means the trauma is below the larynx. It is below the cords and trachea larynx tear. Sometimes is be there and causing all. So only scary at that particular time is a pneumothorax. You see, that is the one which is going outside. We are not worried. But if it is outside the pneumothorax, if possible, I will put in an. If possible, I put an endotracheal tube and try to see whether there is a bilateral pneumothorax, and probably to get an X-ray, maybe a little too much to an X-ray. But if you have a transillumination, put off the light everywhere and put a transillumination on both the sides. That time, if it is well transilluminated, there is a pneumothorax. Or you put a needle and the second you get an air bubble, put a chest drainage on both, and then you put an endotracheal tube to ventilate. And the surgical emphysema all over is not going to create problem. But you must always, if there is a pneumothorax and mediastinal emphysema is the one very critical. So you put a chest drainage on both sides and need an intubation, and after that you evaluate what is the cause, and do not extubate at least 24 to 48 hours so that the tracheal tear will heal for some time. Don't proceed with any surgery. Continue 48 unless it's an emergency. Continue for 24 to 48 hours. Just ventilate with 50% oxygen as much as air, not with nitrous oxide. That will create problem. So ventilate in ICU. Evaluate where is the one. Don't try to take it out and do a bronchoscopy and all at that particular time, because the endotracheal tube, it will be stenting whatever the tear has happened. So keep the endotracheal tube, sedate nicely, ventilate 48 hours, then you evaluate for the bronchoscopy, see what is the tear, where is it tear, whether it can be done, or put the tube back. Then I think that's way of doing it. But if there is a surgical emphysema, you must exclude mediastinal emphysema and bilateral pneumo. Bilateral pneumo, getting that X-ray in the theater will takes time. So just do it, either put in a needle in the second intercostal space, see the bubble coming, or do a transillumination. If it's newborn, then you get it.
Madam, your take on this?
I totally agree. I would not, I would be worried about pneumothorax as well, because obviously there is a leak of air somewhere. Just traumatizing the larynx and causing some edema is not going to give you subcutaneous emphysema. And I would be very reticent to extubate that child right away. I think that the problem with subcutaneous emphysema, even if you don't have bilateral pneumothoraces, is you still have a leak of air from somewhere. And if that air starts to accumulate in the upper neck area and around the airway, it in of itself can cause airway compromise, even if you don't have a pneumothorax. And so I think leaving the endotracheal tube in, doing some more studies to find out where that air is coming from would definitely be the safest thing to do. I would probably give the child steroids, because obviously there's enough trauma that I would want to try to minimize any swelling or maybe scar tissue that might form.
Gomathy, madam.
Okay, that would be very scary.
Yes, Gomathy, madam,
yes, sir. Edward, sir.
Yes, I have a question. First, let me share my screen. So, are you able to see my screen?
Yeah.
So this is the baby I have taken 10 years back, sir. I am not a seasonal pediatric anesthetist, so I asked for your help of your experienced pediatric anesthetist. This is a pedunculated mass that comes from the base of the tongue. It occupies the middle and right side of the tongue. The baby was able to suck the milk without any difficulty. So we tried inhalation induction, but we are not able to put the laryngoscope because our McIntosh are left-handed. Our usual McIntosh blades are left-handed. With that, we will push the tongue to the left side. So we were not able to, since the mass is on the left side, we were not able to introduce our left-sided McIntosh. So we tried with Miller. The mass is in the middle of the tongue. So it was very difficult with Miller. But with Miller, with some difficulty, we were able to intubate the patient. But my question is there any right-handed Millers available? If there is a right-handed Miller is available, McIntosh is available, it will be easier for us to push the mass along with the tongue on the right side. We will be easily intubated the patient. So is there any right-handed McIntosh blade is available? So if you get a case like this, how will you proceed, sir? It's advice.
Yeah, not advice. Edward, when was it done?
10 years back, sir.
Yeah. See, I think that I think this is actually 10 years ago. 10 years ago, these things, we don't have a proper size LMAs those days. I'm talking about maybe about 10, 12 years. We are not so much suprachiasmatic airway device. Second, like Dr. Edward said, I think we always talk about residents or fellows, everything about the left-handed laryngoscope, but we always ask what will happen if a left-handed, they'll say you get a right-handed, but I never seen a right-handed laryngoscope. But we are all asking about it, but I have not seen it. Probably it may be, if you ask the manufacturer, you might be able to do it, but I have not, though I have asked questions, I want it's a left-handed or right-handed, they'll say left-handed, but I have never seen a right-handed laryngoscope. So I think that's I think this is a very probably I'll tell you, this is in this stage, I think the best probably is the fiber optic is the best. I think that is the answer for this particular, because if you do a fiber optic laryngoscope, you can see the posterior extent of the water, because you are seeing only the anterior part, we don't know what is the posterior extent. So the answer right now is probably fiber optic, but I don't know about sometime earlier when suprachiasmatic is not available, we are not skilled in fiber optic. I think you need little bit of experience to make a left-handed as a right-handed scope and try to put it to, but I have not seen. I don't know, Whitten, you have seen a right-handed laryngoscope?
I have not seen a right-handed laryngoscope. And again, I agree with you that right now fiber optic would be the way to go. In the old days, like the baby that we had with the large cystic hygroma, sometimes awake blind nasal intubation is an option, and sometimes asleep blind nasal intubation is an option. It sounds like the baby's airway was okay after you had induced the baby. If you have that sort of a situation, one way of keeping the child asleep while you're doing what can be a little bit of a prolonged blind intubation attempt is to use a nasal airway in the opposite nostril that you're working on and choose an appropriately sized endotracheal tube adapter that fits that particular nasal airway so that you can hook it up to your circuit. And then you can insufflate anesthesia gas plus oxygen. I certainly wouldn't use nitrous oxide in a technique like this for the baby or the child to continue to anesthetize themselves. Now, obviously, that's also going to anesthetize everybody else in the room to a certain extent. Having a suction catheter close to the baby or the child's head to help suction some of those gases away can be helpful. But that the picture of the child from the Philippines that had the severe mandibular hypoplasia and the temporomandibular joint lock, that's how we anesthetized him. We did a mask induction. We had an IV in place. He was an easy airway. We did a blind nasal intubation with him breathing spontaneously, and I had a nasal airway with an endotracheal tube adapter in the other nostril that allowed him to continue to insufflate halothane at the time and keep him deeply anesthetized so that he wouldn't be prone to go into laryngospasm. So that's, again, that's how I would have done this 10 or 15 years ago, but now I'd use a fiber optic.
Ramesh sir, there is a message in the chat box. Dr. Partha from Kumbakonam, he is having the right-sided McIntosh blade, 3 sizes with him.
Thank you, Partha, for the information. Yeah.
Okay.
Maybe we can see it next time. Yeah, thank you for sharing that. Maybe we can see it sometime. Yeah, and we need to use that too. And there are a couple of questions. Can we take a little more questions, Edward, sir? Maybe 2 or 3?
2 more questions.
Sure. Yeah, this question is, I think it's from my teacher, Dr. Mahendran, sir, from Stanley, I think. He has asked us, what are the precautions we should take for intubation in hydrocephalus child posted for VP shunt? Madam Whitten, we can go with you first. What will be the precautions for intubation that you will take in a hydrocephalic child posted for a VP shunt?
Well, I would want an IV in place certainly before starting this, because the child who needs a VP shunt or has a malfunctioning VP shunt is at increased risk for intracranial pressure. And if this is a normal airway, I would do I would pre-oxygenate the child. I would go ahead and induce and do an IV induction with long-acting, with Norcuron, a longer-acting, or rocuronium, a longer-acting muscle relaxant. And then I would go ahead and intubate and then mildly hyperventilate the child and just keep the child anesthetized with, I would use sevoflurane, but I would make sure the child was hyperventilated a little bit.
Ramesh, sir, your views, sir?
Sure, yeah, that's what I would do.
No, that's very clear.
Madam.
Yeah.
I'm sorry? No, Whitten, Madam Whitten, is there any specific positioning technique that you would take? Because a head is going to be very large in proportion to the body. How would you position the child? Is there any specific position?
Well, I would obviously look at the shape of the child's head, and most likely, in order to bring the ear canal more level with the sternum, I might have to raise up the child's shoulders a little bit, just as I would with an infant. We didn't say how old this child is, but I would try to maximize the airway as best I could, placing my rolls or towels strategically based on what was going to make those two landmarks more level.
Thank you, Madam. Ramesh, sir, your views, sir?
No, very clear, because there are two things. I think, see, I'm in a private practice, but what is happening is about 20 years ago, all hydrocephalus, we all diagnosed by the size of the head. If they are big, then we are able to diagnose. Now by the ultrasound and by increasing in the diameter, even 1 inch per, if it increases by 2.5 centimeter in every 2 months, so we are able to detect early these days the hydrocephalus. So what's happening, those days of the difficult intubation and hydrocephalus is almost not there in private hospitals, but in the place we are having in other places who are not on ultrasound, we are not following properly, there may be a big head. So usually what we think, looking at the big head, it's going to be difficult, but I just want to confirm with all the people, to my knowledge, hydrocephalus is not difficult intubations. The positioning is the most important thing. Just keep a small pad on the shoulder and a small ring so that it doesn't move, and usually you will be able to ventilate, and you have to extend it, there's no problem. I don't think, don't get scared. With hydrocephalus, 99.99% it's not a difficult airway unless it's associated with the syndromes. There are some syndromes, Arnold-Chiari malformations, where the cyst is there. All these things are very, very difficult, but if it's a non-syndromic hydrocephalus, usually it is not a difficult airway. The positioning is the key.
Awesome. So very loud and clear. So good IV axis, EMLA cream, good IV axis, and head positioning, so that the ears and the sternum are on the same line, so intubation becomes easy. We got that really loud and clear. And this is just a message I'm going to share from our chat box, and this is from our Dr. Tushar Choksi, who gives all his graphs, and he's very good. And he says he gives mocha ice cubes for sedative pre-medication in child more than 2 years age. His experience is of more than 1,000 pediatric patients with this novel pre-medication. At least a child will allow to put face mask or to put an IV line. Now, Tushar, sir, what is a mocha ice cube? Ramesh, sir?
Tushar can unmute it, and he is the pioneer in that.
Is it possible?
I don't know.
Possible? Edward, sir, can we allow?
Shilpa, can you unmute?
Please allow Tushar, sir. Shilpa? Yeah, I want to know.
Yeah, sir. Name?
Tushar.
Okay.
Tushar Mocha. Because I don't know what a mocha ice cube is, and I'd love to know.
Actually, he has done a lot of work on that. He has even published the paper, but I have not really used it. He said he must use it, but it's Tushar can share with that. It's a midazolam on
Tushar, is he
here?
Left, Shilpa? Okay, she has left. Okay.
She has left. Okay, but we should remember to ask him. Another, I have two questions from viewers who have asked us, Madam, I'll take Madam first. What is your experience for non-operating room anesthesia, particularly for MRI and CT suits? What would be your sedative techniques that you would you follow and you would advise for us?
Well, I typically for MRI and CAT scan don't tend to pre-medicate unless I have a child that's really hysterical and hard to control, because they're outpatients, and I want those children to wake up and be able to be discharged relatively quickly. So I'm now talking about the elective case and the outpatient where they're going to be going home. And so I tend to try to make it as much, like I was saying, make it as much as a game as I can. I tend to be working with an assistant, either another physician's there or another, or a nurse anesthetist. We have nurse anesthetists in our practice. And so I have another skilled pair of hands there to help me start an IV. If I do an IV, a mask induction, I tend to use LMAs in those patients unless they have a risk of aspiration or are going to be in a very odd position. I keep them breathing spontaneously on sevoflurane. I'm not a big user for nitrous oxide for a variety of reasons, including, I think, nausea risk, and I worry about B12. And the fact that it tends to interfere with B12 metabolism. And so I tend to use oxygen, air, and sevoflurane for the procedures. And then towards the end of the procedure, I tend to, again, and I've got a helper there and I have a lot of experience, I tend to remove the LMA deep and wake them up without the LMA. And usually doing it that way, they wake up very quickly and they can be discharged. Our practice is to watch every child for 30 minutes, regardless of how awake they are, but most of them could leave faster than that. I do start an IV after the patient's asleep, and then just run maintenance IVs. I don't give, unless they're doing a biopsy under the MRI or CT guidance, I'm not giving a pain medication or anything like that.
Ramesh, sir? Thank you, madam. Ramesh, sir?
Yeah, actually, Dr. Chris Whitten is giving a very ideal anesthetic in MRI suit, because it is in the United States of America, where it is MRI suit is within the hospital, where you have an MRI compatible machine, you have a MRI compatible monitor, we have a LMA for the time. I think Dr. Whitten will be surprised if she come to Chennai and see the MRI and CT scan center or on the roadside, and more of CT scan and MRI center are there, more than the tea shop and the coffee shop in Chennai. So it is very difficult to have. First is Dr. Whitten, sometimes you will be surprised, they may not even have an oxygen cylinder to give oxygen that particular time. So I think that's what it is, that LMI, putting a CO, it's all agree. The whole of my Chennai, in the only 2 centers I've got a MRI compatible machine. So that's you can imagine that in a whole corporate in that. So I think what the best, I have gone to almost all the centers all over Chennai, in all over the streets, but I make sure there is an oxygen cylinder, there is a circuit which is being there. I put an IV line, whatever I don't induce with CO, I put an IV line, make sure everything is all right. And then what I do is I give little propofol 2 milligrams and take a monitoring line about 400 centimeters, connect it away, and then keep intermittently, continuously giving through the hand. If you're an infusion pump, it's very good. But if the infusion pump, you need to be away from the Faraday's line, that is quite far from your MRI circuit. If you don't have infusion pump, then you can give with that, but during that particular time you make sure that head is extended very well, it doesn't get obstructed. And I don't give any ketamine or anything, because all narcotics, ketamine will increase the recovery time, lot of secretions. So I just maintain a propofol, because the MRI doesn't need an analgesic, just need a sedation and little bit of propofol, and you see the monitoring only the respiration, chest rise. Sometimes even I put a cotton bug in the nose so that the cotton one moves up and down, seeing that it is moving up and down. Very few centers have an oximetry, but if you have an oximetry is very good. So you can give oximetry, nasal oxygen, and then propofol continuous infusion, and don't do too much, just 1 milligram. Once they say it's over, so all positioning, everything is done. Your position should be, head should be extended, that should not be obstructed, and your oxygen should be available, and continuous monitor. Don't sedate and come out of the MRI room to the console room. You must stay in the MRI room because you will be the first one to diagnose there any obstruction.
Yeah, I absolutely agree that I practice a charmed existence with MRIs and CAT scans. And I agree with what you're saying. I have done a fair amount of travel around the world for volunteer groups, so I know exactly the circumstances you're talking about. And I have used the technique that you're talking about when I've gone out to our radiation therapy for treatment for children, because there we don't have an anesthesia machine and we have to bring everything with us. So we have to bring an ambu bag, and we don't have any sort of a circuit. They do have an oxygen tank. We have to bring all of the appropriately sized monitors. And I do exactly as Dr. Ramesh is suggesting, start an IV, run either a propofol infusion or do intermittent propofol injections, and just make sure that the airway is open, but that I have all the emergency airway equipment there in case I need it. So totally agree.
In my car boot, I have all the drugs, all the equipments, everything in the car at the back to go into MRI or a CT scan, except the pulse machine, because it's very, very important that in the scan center they don't concentrate on those equipments. So I think it's important you have feeding tube, proper size endotracheal tube, suction catheter, and all your airway and ambu, Jackson Reese. I think you must have everything if you are going to this particular room. It's very, very important. You cannot shout out those people, they may not have all the sizes. When your operating room ourselves have not all the sizes, how can you expect the scan room to do everything?
Thank you, Gomathy madam. We will finish with the exhaustive discussion. So, my personally thank Dr. Ramesh sir for sparing his wonderful time, and also Chris Whitten, waking very late night in the other side of the planet and answering all our questions. Thank you very much, Mr. Whitten. So, as a formal vote of thanks, I request Prasad sir, please give the vote of thanks.
Shiva sir, I think Shiva sir is caught in an emergency.
Okay,
sir.
thank you very much. I thank the A1 Logics, the host and the sponsors Akrula and Anaesthesia TV, and thank everyone and the viewers also. I thank. With that, we will conclude this session. Thank you one and all. Thank you, Gomathy madam, for a wonderful coordination. Thank you. Thank you, one and all. We will meet the next week.
Thank you, madam.
Thank you very much for the honor.
Thank you. Bye.
Thank you, Ramesh sir.
Bye.
Thank you. Take care.